Okay, so thank you for the invitation. Thanks, Dr. Abdul Wahab. And thank voice is reaching you now. So can you hear me, please?
Yes, we can hear you, Dr. Khalid.
Okay, okay, okay. So I'll start to my talk. I'll try to be to sticking to the time about the central neck dissection,
Uh,
and as
One
we
point, sorry,
can.
Dr. Khalid, if you can share your screen if you have it available. Also, if you feel comfortable with the camera.
We know that involvement of the lymph nodes and the macrometastases are observed in about 80% of cases, and the identification of the lymph nodes in the central compartment is not that simple because for the neck ultrasound, which is sensitive for the lateral nodes, it's sensitive for the central nodes in not more than quarter of the cases, 25%, less than 25%, even in the hands of the experienced radiologists. As for the indication, when we do the central neck dissection, we have several indications, mainly when we diagnose a lymph node metastasis. Sometimes it can appear in the ultrasound, not that much as we have told now. And even if I am proving that by a fine needle aspiration, another thing with the high risk features of the primary tumor, like the aggressive histological features, like the presence of aggressive variants, or even with the extrathyroidal extension. Another thing is the site and the location of the tumor, sometimes with the large tumor more than 4 centimeter, sometimes with the proximity to the trachea or the esophagus. And here we have a good article talking about the correlation of the primary tumor site and the central compartmental lymph node metastasis in the well-differentiated thyroid cancer. And they got a conclusion in that even in well-differentiated thyroid malignancies, they found a high incidence of central compartment lymph node metastasis, even with smaller sites. And I think that this can we will go now to the fourth indication, which is the high serum thyroglobulin, either it's persistent or rising, and in recurrent cases, either in the recurrence of thyroid cancer in the central neck compartment after the initial treatment, either it was surgery or even a radioactive iodine. Affection of the lymph nodes in that compartment may be between 20 to 50% in most serous, and that metastasis can be present even with primary small tumors, even if they don't have the extrathyroid extension. And the number of nodes in the central neck dissection specimen, it's important in predicting the central compartmental recurrence. We have samples talking about an average of 4, ranging from 1 to 16 lymph nodes, talking about the prophylactic central node dissection, because this is one of the debatable issues when we talk about the central neck dissection. And we have here a meta-analysis that was published about this issue. In this meta-analysis, they have evaluated the effectiveness of the prophylactic neck dissection, talking about the oncological safety and about also the surgical safety, talking about the morbidities. They have seen that in the group of patients with prophylactic that have underwent prophylactic central neck dissection, they have lower recurrence rate, which was a bit significant, whereas with the incidence of a permanent hypocalcemia and even a transient hypothyroidism. But for the other morbidities like the transient hypocalcemia, permanent hypothyroidism, both groups that underwent the total thyroidectomy or that underwent the total thyroidectomy and the prophylactic central node dissection, there was no difference talking about the other morbidities. And so compared with the total thyroidectomy alone, total thyroidectomy with prophylactic neck dissection, and I mean here by prophylactic that cases that does not have a proof that the central nodes are positive, either radiological or even by a fine needle aspirate. So it may reduce the local recurrence, and in the good hands, it's not associated with higher morbidity. And so they had this conclusion that the total thyroidectomy with the prophylactic node dissection should be recommended for the patients with CN0 papillary thyroid cancer. But when we go to the current guidelines and the recommendations, if we talk about the ATA guidelines, they have defined the patients into the low-risk patients, and for them, they see that prophylactic neck dissection is not routinely recommended. For the intermediate and the high risk, they advise for it, and the extent of dissection here should include removal of all the lymph nodes from both recurrence. It's between the both carotid sheaths. And for the ESCS guideline, they also provided recommendation talking about a selective node dissection for smaller tumors, and they mean here that not removing all the central node compartment. And for larger tumor, they have like something like a modified radical neck dissection, removal all the groups in the group 6, which is the nodes, and even extending into group 7, like the superior mediastinal nodes. It may increase the morbidity, but they saw that it will decrease the incidence of the local recurrence. Also talking about the NCCN guideline, they have talking about the initial surgery that should include consideration of central nuke dissection when there is evidence of extracellular extension, clinically apparent lymph node metastasis, or the high-risk histology. And for the extent of dissection here should be removal of all the lymphatic tissue within the central compartment, and in selected cases, they may extend into group 7, which is the superior mediastinal lymph nodes, because they are afraid of the risk of increasing the morbidity. Unilateral or bilateral, will I do into one side or both sides of the central compartments? For smaller tumors, for unilateral affection of the central nodes, or for unilateral tumors, I may go into one side of central nodes. When it's bilateral, multicentric, bigger tumors, I may go into a bilateral tumors. And so when we go into talking about the complication, we have like immediate complication related also to the thyroid surgery, like the hematoma, the seroma, maybe an injury to the adjacent structures, and here the risk may be a bit higher with the central neck dissection, like the recurrent laryngeal nerve injury, the parathyroid gland injury with the either the temporary or the permanent hypocalcemia, sometimes the wound complication like infection and delayed wound healing, and maybe the Chi leak will be one of the factors that if it happens, it will worsen the wound healing. And the management here should be adherent to the anatomical planes and the meticulous surgical technique and the good hemostasis, and also the immediate identification of such complication with a good monitoring and drainage. I'm from Mansoura Oncology Center. That's related to a big university in Egypt. I'm just showing some of our trials, starting from the first one, talking about the unifocal differentiated thyroid carcinoma smaller than 1 centimeter. And we had here a conclusion. This was published 14 years ago. And also addressing some other topics like the strange presentation of the metastasis, and also talking about the incidence of papillary thyroid carcinoma after liver transplantation, because we had one of the big centers for liver transplantation, which is beside our center. Also, we have searched about the prognostic factors related to the papillary thyroid cancer. Also, we have a good article that was published 4 years ago, thyroid cancer associated with the Hashimoto thyroiditis, some of the markers related to the prognosis of the papillary thyroid cancer. Um, we studied the new term that was released years ago about the non-invasive follicular thyroid neoplasm that have downstaged some of the well-known cancer into a benign neoplasm, and also the good article that we have recently published maybe 2 months ago about the impact of age on the central lymph node involvement in the papillary thyroid cancer. We know that this is not the usual field after central compartmental, but sometimes for the educational issues, we have to do such an aggressive dissection. We used to do this in the earlier cases, but nowadays we are more conservative. This is some of the specimens that we had after the surgery. And for our group of patients, we in the last article that we have published, we demonstrated our setup that was during the last 12 years with a total of 324 patients that were assessed for such cases. The mean age was 39, which is the usual average for the papillary thyroid cancer. And also we had in our cases like asymptomatic hypocalcemia in about 19% of cases. And we have seen that this declined in the last years with the increasing of the learning curve, and also the recurrent laryngeal nerve that was noticed in nine. I'm sorry.
2 minutes.
Okay, I'm reaching the end now. And this is for the pathological features. If we go, and we had this conclusion that this central node dissection is associated with the low morbidity and most commonly maybe the hypocalcemia, and that radiology had like a lower accuracy and sensitivity in detecting the central node disease. Patients that spread to the large nodes will almost have a central nodal spread, and also patient aged below 20 years had a higher probability of harboring malignancy in the central nodes. Talking lastly about the recent advances, maybe using the selective and the modified approaches in central node dissection, maybe the minimal invasive, and we had such experience in our center, the enhanced imaging and navigation to detect the central node dissection, molecular profiling, and the enhanced recovery protocol. So if I want to deliver a whole message about such a topic, so central node dissection has evolved from radical procedures to more refined and selective techniques. The historical progression reflects a shift towards preserving the functional anatomy. Central neck dissection is indicated in patients with differentiated thyroid cancer when there is evidence of lymph node metastasis, high serum globulin, or leukoregional recurrence. These indications are based on the guidelines that we have illustrated. The extent of neck dissection in thyroid cancer is guided by the risk stratification, and we have reviewed with each other the recent guidelines about central neck dissection. And this is my last slide, and this is my department, surgical oncology department from Mansoura University Center. And this was my last slide. Thank you, and thanks again for the invitation.
Sure.